39-year-old male, known asthmatic for last 10 to 12 years, and he was on inhalers, Ventolin and Selmicort inhaler, on and off, and then he was up and about, and function class was 1, and basically he is.
What's the age of patient?
Age is 39 years.
39 years, male, known asthmatic.
Known asthmatic. Then he presented with a complaint of shortness of breath, function class 2 to 3, and productive cough since last 1 month. 1 month. And he had fever, low grade undocumented, initial days, then was multiple GPs for this problem, and somewhere he had an X-ray, chest X-ray, which was normal, and then he was taking medicines, but no relief. Then he went to some other GP. He advised him an echo.
Okay, continue.
Then sir, echo was done from KISG. Then he got referred here.
So let's hold here. It's a background of a 39 years old male with history of asthma in the background, and presently presented with cough,
shortness of
RTI kind of thing.
Yes, sir, exactly.
And then in between that cough, did he had SOB, PND, orthopnea, all other things as well?
Yes, sir, shortness of breath, and but not orthopnea.
No, there is orthopnea present since.
That was with last 1 month.
Last 1 month.
Or the background of asthma.
He had SOB since 6 months, which has worsened since
Last
last 1 month with orthopnea pain.
So what's your thought about it? Here is a background before echo, because you have to judge a person with symptoms first. That's what you are really getting in terms of what the problem your patient is facing. Although he is a known case of asthma, so most of the time one thinks that it may be an aggravation of asthma
or
with cough and RTI and other. But what thing really make you think of that he may had heart failure? What are the things? How do you differentiate in a background of asthma with new symptom, whether it's heart failure or aggravation of asthma? How you differentiate that?
Sir, we will check whether he is developing an edema, bilateral pedal edema, or...
Pedal edema is too early for even heart failure patient, isn't it? Because initially you got increased LV filling pressure, which lead to pulmonary edema rather than pedal edema. Pedal edema is a very late thing. It really translates two things, either a right heart failure or severe volume overload with normal right heart. These are the two. But they are in a chronic heart failure patients, where your patient has, so not an acute situation, you're looking for pedal edema to differentiate aggravation of asthma or a new heart failure. What else?
Sir, on auscultation, is there any murmur or gala?
That is for etiology. But pure heart failure, you have to think of just symptoms, then basic signs, and then preliminary investigations. जी कुछ कहना चाहते हैं? PND orthopnea are very categoric of heart failure rather than asthma, because aggravation of asthma means just wheezing and that classical presentation. So if you are getting something new other than asthma aggravation, and then your clinical examination, bilateral wheezes, although in acute situations of heart failure, when your patient is severely tachypneic, function class 4, even can't lie down, desaturating, at that moment you can get wheezes as well. That is not asthma. But not in a stable heart failure patient. You won't get wheezes. So in a stable, meaning by function class 1 or 2 heart failure patient still wheezing, then this is something else. Can you define heart failure? Because we are starting to discover or really make a diagnosis or a clinical impression of heart failure in a patient who's pre-existingly asthmatic with new SOB symptoms. So first we need to know the definition. Sir, how to define heart failure. Sir, because then you will going to search your clinical condition according to that definition. whether your patient is coming under that definition or not.
Sir, there are the multiple definitions of the heart failure.
New definition, and they have worked a lot. Multiple guidelines have worked to make a final new definition of heart failure.
Okay. Sir, when
But you can give background as well.
Yeah. So generally we can say when there is the inability of heart to supply the enough.
That is old definition.
This is the
Inability
old
of heart to pump the blood
that
coming
can
to
meet
it.
the body demands. But sir, currently we can say when the ejection fraction.
But this definition was at that moment when we were just considering systolic heart failure as a heart failure, HFrEF. But now you have a vast spectrum of heart failure, starting from HFpEF, marginally reduced, and reduced EF.
Reduced, yeah.
So your definition should be covering every kind of heart failure.
Okay. Sir, so when the EF is more than 60%, that's the normal EF. But when the EF is, comes down to the up to the 55%.
General universal definition of heart failure.
Yes, sir. I know only this one.
Do you want to add anything?
So it's a syndrome which is either caused by any either there any syndromes which causes signs symptoms of any pulmonary condition or systemic condition, and there will be raised enzyme levels there will be raised pro-BNP levels, which is either caused by any functional defect of the heart.
So you have to fulfill two things with symptoms. And symptoms, heart failure is a clinical syndrome. Syndrome means constellation of sign and symptoms. And common sign symptoms would be SOB, PND, shock state. These all things are common sign symptoms of heart failure caused by any structural or functional cardiac abnormality, and along with elevated BNP or evidence of systemic or pulmonary congestion. If you have these things with symptoms, then you will label your patient as heart failure. So इस patient में हम जब heart failure और asthma को differentiate करना चाह रहे हैं, so what important investigation you will do? Along with your clinical judgment with which you are trying to pick systemic and pulmonary congestion. So heart failure diagnosis needs, along with symptom, evidence of systemic or pulmonary congestion or a raised BNP level. These two things are needed. And once you got evidence of these, then you need to do echocardiography. In this patient, you already told that echocardiography showed
LVF of 10 to 15% with dilated chambers.
Now you are clear that this patient is a case of HFrEF. Otherwise, your heart failure can be HFrEF, HFpEF, or marginally reduced EF. Now, if you are dealing with HFrEF on your initial assessment, now the second thing comes in cause, reason as well as एग्रीवेटर्स. ये दो चीज़ों का मालूम करना हार्ट फेलियर के पेशेंट में ऑब्लिगेटरी है. अब खड़े होते हैं जस्ट टेलिंग हार्ट फेलियर इज नॉट एन इटियोलॉजी. हार्ट फेलियर इज सिंड्रोम ड्यू टू डिफरेंट इटियोलॉजीज. सो व्हाट डू यू थिंक द कॉज टू बी इन दिस पर्टिकुलर पेशेंट?
Maybe he is having ongoing viral myocarditis or cardiomyopathy.
Possible,
underlying
because the things started on a background of asthma with febrile illness and respiratory tract infection, and all things happen in between. So one, myocarditis. Any other possibility with this background? Because you narrated that his troponin is also
raised.
So then
Also ischemic
possibility. 39 years male. Are there any risk factors?
No.
So
Is
now
not a
we
smoker
have a
or-
tie between a myocarditis or IHD. So points in favor and against of these two different possibilities. Anyone with this background, whatever you are hearing. Ji.
He has history of intake of drugs for Hydra and Imatinib
Okay.
last 2 years
So
back.
that fevers myocarditis.
No, yes sir. Dilated.
So he was on drugs for
Hydra
what
for
reason?
hydroxyurea. And
Why?
sir, he told that he got some infection of fever and with cough. So yeah, since with edema, pedal edema, he went to some local GP. They advised CBC. He was consistently having raised WBCs with eosinophils. Then he went. Someone referred him to NIPT. There he took Hydra for 2 years. Then he got his symptom free. His weakness was also improved. Then he stopped. Then further after 8 to 9 months, his symptoms started aggravating, and then
But
he
how
went.
then you explain his raised troponin, 25 troponin? Although if you take this troponin out, there is nothing in favor of ischemic heart disease. Because no chest pain, no ST elevation, no admission for ACS, nothing in favor of, I won't consider this troponin. Because just test is not enough. You have to correlate as whole.
Sign and symptom.
Sign, symptom, background, ECG, all progression. And here considering his febrile illness with this background of and biventricular failure
Biventricular.
and severe generalized LV dysfunction. So things are going in favor of some muscle disease rather than
Ischemic attack.
ischemic. But he's a young patient, 39 years. You can do assessment for coronaries. Even direct angiography or CT angio or whatever to assess the atherosclerotic risk of this patient as well. But this all background is going more in favor of a muscle disease rather than ischemic heart disease. How will you manage him? From right now, how will you manage? Is there any change in name of the stage which we give to the heart failure patient A, B, C, D in the new guidelines? कोई और लेबल हमने चेंज किया है स्टेजेस के लिए A, B, C, D के लिए for a layman to understand these terminologies. Now stage A is called at risk of heart failure. So all those who are at risk of heart failure, like this patient when he was on drugs which can precipitate muscle disease, he was stage A heart failure. Even hypertension, diabetes, all they are stage A. Meaning by you should be always looking for, they may develop heart failure at any moment with or without symptoms. And both kind of heart failure, HFrEF or HFpEF. Then B, stage B is pre-heart failure.
Pre-heart failure, progressive.
Stage A, risk of heart
risk of
failure. Stage
progressive
B,
failure.
pre-heart failure in a way that they have started developing some structural problems but no symptom up till now. Because we have made the definition of heart failure as constellation of sign and syndrome. Sign symptom हो और उसके साथ फिर वो सब कुछ हो, then they are heart failure. So stage B is pre-heart failure. No symptom but started having changes which may develop, may tip this patient into. Stage C is clear-cut heart failure because now your patient is having symptom. And stage D is advanced heart failure when you need more than medication. Now let's take this patient. How will you manage this patient?
He's admitted with the acute decompensation of heart failure. Then
let's see, ER people have made him a bit stable. Now you are dealing a patient with relatively stable hemodynamics and they have just given him IV furosemide. And now you are taking this patient from them, from the bed now, and you will start treatment for heart failure. So how will you treat him?
so first diuretics. We can give diuretics.
According to diuretics, what dose? Which diuretic?
According to the creatinine clearance and
No, according to the
potassium
volume
and
status
volume
of your
status.
patient. If
Volume
he is
status of the
euvolemic, you need no furosemide. And you expect that just taking care of his intake and salt, water intake, you can manage his volume, no furosemide is needed. So diuretic is only indicated if your patient is
volume.
hypervolemic. So you have to judge your patient according to that. Since he is just from the ER, so you'll keep low dose of diuretic to see how he responds to your diuretic dosages. If he is still getting more volume on that dose, you need to increase the dose. And then decide at the time of discharge what minimum dose he needs for his routine intake. So diuretic, okay, according to patient status. ARNIs. What things you will look prior to starting ARNIs?
Creatinine clearance, and if prior he
Fat,
was on
potassium, blood pressure.
blood pressure.
If these three things are okay, you can start ARNI. What else?
Beta blockers if it's out
Beta
of
blockers,
failure.
obligatory drug for heart failure, but you need to see any bronchospasm. He's asthmatic, so you can't give beta blocker. If he's having
selective beta
ongoing
blockers?
bronchospasm, if stable, yes, you can. Selective beta blocker can be tried. So
So
beta
as-
blocker, heart rate, blood pressure, and asthma,
Asthma.
or any blocks.
SGLT2 inhibitors
SGLT2. What else?
and
MRAs.
MRE.
And ARNI, not just ARNI, any RAS blocker. ARNI, ACE, or ARB.
ARBs.
So these four drugs you have to start right from the beginning in a patient with HEF-REF. Now out of these, it's amazing that just SGLT2 can be started in anyone. You don't have to look many things.
Exactly.
Pressures, no issue. Renal function, no issue. Heart rate, no issue. Bronchospasm, no issue. You can give SGLT2. Just repeated UTIs or insulin dependent diabetics. These two groups you can't give SGLT2. So if even if his pressure is 90-70, you can give SGLT2. But you can't give ACE, ARB or beta blocker. MRA again, need to see creatinine, potassium and everything. So it's seen that this is the drug which can be given to everyone right from the beginning, unless and until you have other issues with him. So you have to look for his blood pressure because you can't start all four together. What is his blood pressure?
Blood pressure was low today. That was 90/50.
So I
And at
think
night was 150.
ACE, ARB, ARNIs are out. Beta blocker is out. MRA 25 milligram, yes, you can. If potassium and creatinine are okay, that you can give. And usually you need to give it in combination with furosemide because he need diuretic as well because he's just from ER to came to you, so he may be needing oral diuretic. So I think he should be given furosemide along with spironolactone and then SGLT2 and rest according to the hemodynamic. Once his getting pressures up, his heart rate is adequate, he's having no asthma. If his rate is increased, can you give anything? Ivabradine, very good. Because his pressures are borderline, he's asthmatic as well. But with that pressures, if heart rates are more than 70, you can give ivabradine to this particular patient. Okay.